Behavioral Science, Diagnostic and Statistical Manual, DSM-5. Section 2, Schizophrenia. Schizophrenia is a psychiatric disorder which is classified as a thought disorder. Now, this is, of course, a disorder that affects your thinking, how you relate to reality, or interpret reality, I should say, and it has specific criteria. One of the criteria includes delusions. Now, delusions are fixed and false beliefs. These are beliefs where the patients believe them to be true, but you know that they're not true. Word of advice: never confront a delusional patient in the emergency room. You're not going to get anywhere, and you'll probably just make them agitated. So a lot of times that will be a choice on the exam. Never put that down. In DSM-4, the delusions of schizophrenia had to be bizarre. In DSM-5, they removed that criteria, so understand that they probably will still be bizarre on your exam, but they don't have to be bizarre. So what do I mean by bizarre delusions? You believe that you have a microchip implanted in your brain and the government is following you. Now, I'm sure that some of you believe that our government actually does that, but in reality, I don't see that happening. Also, hallucinations are common in patients who have schizophrenia. Schizophrenics can either have auditory hallucinations or visual hallucinations, but what you typically find are auditory hallucinations, and these tend to occur in about 75% of schizophrenics. For the purpose of the exam, whenever you see a question and a patient is experiencing visual hallucinations, what I would like for you to think of first is a diagnosis of alcohol or any other drugs. For example, patients who have alcohol withdrawal delirium typically have visual hallucinations where they tend to see little things. They'll tell you that they're seeing little insects or little spiders crawling on the wall when actually there is nothing there. So auditory hallucinations are much more common in the psychotic disorders. They hear voices which tend to be demeaning, negative, derogatory, and somewhat scary. Patients also have problems with their affect. Now, the affect is how you express your emotions. So here we're going to look at the patient's face and we're going to see if they have any emotion there. Schizophrenics can have either a blunted affect, which is less than normal, or a flat affect, which is no emotion whatsoever. Patients can also experience what is called loose associations, where you are going from one topic to another without any connection whatsoever. So, it's raining today, yellow bananas. That's what loose associations is all about. So when you're talking to these individuals, you're not going to be able to comprehend anything that they're saying. They tend to have problems with reality. They have distorted perceptions. And overall, their functioning must be impaired. This is one of the disorders where it is much harder for the patients to return to what is called the premorbid level of functioning, as you typically find in patients who have depression or anxiety disorders. This is also a disturbance in your behavior and form and content of thought. What is the hallmark of schizophrenia is that you have to have the symptoms more than 6 months. And this is very important because when you see schizophrenia questions, the first thing I want you to focus on is how long the patients have been having these symptoms, because there are 2 other diagnoses that are possible, and we will review these in the next slide. Let's continue to review schizophrenia and other diagnoses which are schizophrenia-like. The first one is called schizophreniform disorder. It is exactly like schizophrenia. However, the symptoms must be more than 1 month and less than 6 months, and that is essential in the diagnoses. And the only difference between schizophreniform and schizophrenia is duration of symptoms. So schizophrenia is more than 6 months. Schizophreniform is more than 1 month, but less than 6 months. Brief psychotic disorder is another type of disorder that is almost identical to schizophrenia, except the duration of the symptoms. In brief psychotic disorder, the symptoms must occur more than 1 day and less than 30 days. So technically, you can see the patient 3 times and have 3 different diagnoses. If they present at 2 weeks of psychotic symptoms, hallucinations, or delusions, you give them the diagnosis of brief psychotic disorder. If you're seeing them at 3 months of hallucinations and delusions, then you call it schizophreniform. But if you're seeing them in that 7-month period, then you call them schizophrenia. So remember, time is essential in differentiating one disorder from the other. Now, what if the question does not mention time at all? Then you should put schizophrenia as the correct answer. If you remember the different types of schizophrenia, the paranoid, the residual, the catatonic, the disorganized, DSM-5 removed all of those things, which is a great thing for you because it's one less thing you have to study. So all you have is a diagnosis of schizophrenia, and you don't have to worry about what type of schizophrenia the patients have. Now that we learned how to make the diagnosis of schizophrenia, let's review the epidemiology of this disorder. This is a disorder that has equal incidence in men and women. However, men tend to get the disease much younger than women. Men typically get the diagnoses between the ages of 15 to 24, whereas women get it between the ages of 25 to 34. So what does this mean? Men typically tend to have a worse prognosis. So men will tend to do worse in the hospital as well as out of the hospital, and they tend to have worse level of functioning. Schizophrenia affects the population at about 1%. Now, this is seen everywhere. However, there is some data that you tend to see less chronic and severe forms in developing countries as opposed to the developed countries. Another theory of schizophrenia is that it is associated with the socioeconomic status. This is a theory called the downward drift theory, where you have an individual who's probably in a higher socioeconomic status, develops the disease, is unable to function, therefore drifts to the lower socioeconomic status, hence the name downward drift theory. Schizophrenics do attempt suicide. About 50% of them attempt, but only 10% of them succeed. Usually, the number one psychiatric disorder linked to suicide is going to be major depressive disorder. When we look at prevalence rates for this disorder, we do know that there is some sort of genetic linkage for patients who have schizophrenia. And this is evidence when you look at the concordance rate of twins. When you have monozygotic twins, you have a 47% chance of developing schizophrenia in the other twin, whereas dizygotic is 13%. If you have one parent or one sibling who has schizophrenia, you have a 12% chance of developing schizophrenia. But if you have two parents that are schizophrenic, then your chance jumps to 40%. Heritability index is something that you should memorize. It's a simple formula which basically tells you what percent of this condition is due to genetic factors. They will give you the monozygotic and the dizygotic rate, and they will tell you what disease it is they want you to figure it out for. So, for example, if they want to know what percent of diabetes is due to genetics, they will give you a number for monozygotic and a number for dizygotic, and you just have to plug in the formula and figure it out, and that number will be on the answer. The heritability index formula is monozygotic minus dizygotic divided by 100 minus dizygotic. Please remember this because it is a common formula that appears on the exam. So because we believe that schizophrenia does have genetic linkage, we know that there is a risk in biological relatives that are 10 times greater than the general population. Now, although the schizophrenia paranoid type was removed from the DSM, let's just review what paranoid symptoms are. And these are usually patients who have either delusions of persecution or grandeur. If I believe that I'm Jesus Christ, I have a delusion of grandeur, which is pretty bizarre. Or if I believe that I'm being persecuted by the lizard monster, that's also a type of paranoid symptom. So you just have to be aware that these are paranoid symptoms. You would give them the diagnosis of schizophrenia, but understand that schizophrenia paranoid type does not exist anymore. And usually when you have paranoia, it's usually accompanied by auditory hallucinations. Although schizophrenia catatonic type does not exist, what do we call catatonic symptoms? So these are patients who basically have complete stupor or decrease in spontaneous movements. So they could be mute, meaning they're not talking to you. They can be exhibiting negativism, echopraxia, where they're imitating your actions. They also could be very rigid. They could stay in fixed positions for extended periods of time. You could see these patients not speaking, not participating in groups, and staring at the wall for hours. The ability to move these people into awkward positions is a term which was called waxy flexibility. So to continue with the catatonic symptoms, you will probably find psychomotor disturbances in these patients where they can either be extremely excited and agitated or not moving at all. So when they're in their excited state, they could be incoherent, they could be violent, they could be destructive. In these situations, they could actually hurt themselves, or because they're running around like the Tasmanian devil, they could collapse in exhaustion. And they could also have these repetitive stereotype behaviors. When we look at the symptoms associated with schizophrenia, they're going to be divided into two types. You either have what are called positive symptoms or negative symptoms. The positive symptoms have been linked to the dopamine receptors, and they are things such as delusions, hallucinations, or bizarre behavior. These are symptoms that are easier to treat. These are symptoms that respond to all of the antipsychotic medications. And one way to remember them is that this is what schizophrenics have that normals do not. The other type of symptoms that you find in patients with schizophrenia are what are called the negative symptoms. These are the ones that are associated with the muscarinic receptors, and these are things such as flat or blunted affect, apathy, anhedonia, which is absence of pleasure, mutism, the psychomotor retardation, the patients who basically are not showering, have a flat look on their face, are not interacting with you. These are harder to treat, and these type of symptoms typically respond to what are called the atypical antipsychotics, which are the drugs like risperidone, olanzapine, etc. An easy way to remember these symptoms is that this is what normal people have that schizophrenics do not. So when we look at predictors for prognoses, you could either have what are called good predictors or bad predictors. Let's review some of the good predictors for schizophrenia. Having paranoid symptoms is a good predictor. Why? Because they respond to treatment of all kind. Also, they tend to give you a better prognosis as far as your level of functioning. When you have the diagnoses later in life, it's a better prognosis than earlier in life. So therefore, women tend to have a better prognosis. If you recall, women would tend to get schizophrenia between the ages of 25 to 34, whereas men would get it between 15 and 24. Having an acute or quick onset is also a predictor for a good prognosis. Why? Maybe something happened to you, you became psychotic, so you probably will go back to your premorbid level of functioning, so you're having a better chance. Positive symptoms are also good predictors. Why? Because they're easier to treat. Not having a family history of schizophrenia is a good predictor. And having a family history of a mood disorder is a good predictor as well. Whenever you compare mood and psychotic symptoms, the more mood symptoms you have, the better the prognosis. The more psychotic symptoms you have, the worse the prognosis. So if you have a family history of schizophrenia, that's a bad prognosis. But if you have no family history, that's a good prognosis. Same thing applies with mood. If you have mood disorders in your family, it's always better than having psychotic disorders. And if you have no structural brain abnormalities, then that is also considered a good prognosis. One of the brain abnormalities that you can find in patients who have schizophrenia could be things like enlarged ventricles and areas of hypodensities in the frontal lobes. This is not something that you always find with schizophrenia, but it has become or can become an associated finding. Now, we believe the theory of schizophrenia is linked somehow to dopamine. Patients who have schizophrenia are believed to have too much dopamine. Why did this theory come to be? Well, one of the reasons is that antipsychotic medications reduce the symptoms of schizophrenia. We know that antipsychotic medications block dopamine receptors, therefore reducing the amount of dopamine. We also know that there is a strong correlation of clinical efficacy with drug potency in these dopamine receptor antagonists. We also know that there have been findings of increased dopamine receptor sensitivity in postmortem studies of patients who have these disorders. And we've also seen this when doing PET scans of patients who have schizophrenia. Although dopamine is believed to be the main neurotransmitter linked to schizophrenia, serotonin also plays a crucial role. Studies now indicate that the genes involved in serotonergic transmission are implicated in the pathogenesis of schizophrenia. We also know that the hallucinogenic drugs, such as LSD, affect the serotonin receptors, and we know that these drugs can cause hallucinations, therefore producing psychotic-like state. We also know that the newer medications, which are called the atypical antipsychotics, such as clozapine, risperidone, etc., have high affinity for serotonin receptors, and they work very well on patients who have schizophrenia. One interesting finding is that scientists have discovered that serotonin rises when dopamine falls in some areas of the brain, therefore explaining why the atypical medications will be effective. We already know that dopamine and serotonin are implicated in schizophrenia, but now glutamate has also been linked to this disorder. This is now believed to be one of the major neurotransmitters in the pathways to schizophrenia, specifically its symptoms. We know that the NMDA receptors regulate brain development. We also know that phencyclidine and ketamine block the NMDA channel, therefore creating positive and negative psychotic symptoms which are identical to schizophrenia. Any drug which indirectly enhances NMDA receptor function can reduce negative symptoms and therefore improve cognitive function. So, when looking at the neurotransmitters, we know that dopamine, serotonin, and glutamate are essential in patients who have schizophrenia. Schizophrenics have been known to have problems with smooth eye pursuit, or smooth pursuit eye movement, or SPEM. This is the ability of the eye to follow a slow-moving target. Patients who have schizophrenia are unable to do this, and they have what are called saccadic eye movements, which is an abnormality in smooth eye pursuit. Now, why is this important? Because it is something that schizophrenics have, but also it is believed that their first-degree relatives also have. And that is why this saccadic eye movement has been considered to be a trait marker for patients who have schizophrenia. As mentioned earlier, I stated that schizophrenics have areas of hypodensities in the frontal and the prefrontal lobes. And if you remember, the functions of the frontal lobes was where we had executive functioning, personality, abstract thinking, etc. These are all things that tend to be different in schizophrenics. What studies have shown is that schizophrenics are showing decreased physiological activity in the prefrontal lobe when faced with any of these cognitive tasks. And this has been evidenced using PET scans, which shows areas of hypodensities in this area. When schizophrenics are given the Wisconsin card sort test, which is a test sensitive to prefrontal dysfunction, they will definitely find deficits in that area. And when compared to patients who have frontal lobe injury, their profiles are very similar, meaning they have problems solving tasks, they can be apathetic, and they have cognitive dysfunctions. Some brain structural and anatomical abnormalities of schizophrenics include larger ventricular size and ventricular brain ratios. So what the studies have found is that patients who have the worst prognoses tend to have the greatest ventricular size. And this, of course, is associated with more negative symptoms. And if you recall, these are the ones that also had the least response to medications and harder to treat. Patients can also have cortical atrophy, smaller frontal lobes, as well as atrophy of the temporal lobes. As mentioned earlier, there are certain associations between cortical abnormalities and schizophrenia. We know that there is a correlation between the ventricular size and the prognoses of the illness. The greater the ventricular size, the worse the prognoses. We know that there's more dilatation with the negative type symptoms of schizophrenia, including flat affect, poor grooming, social withdrawal, and anhedonia. Dilated ventricles are not unique to schizophrenia. Other disorders have them, including mood disorders, such as bipolar and major depressive disorder, as well as schizoaffective disorders, and also cognitive disorders such as Alzheimer's. It is also believed that the limbic system is involved in schizophrenia, and they actually believe it is the site of primary pathology for schizophrenia. Patients who have this disorder will typically have changes in the hippocampus, the parahippocampal gyrus, the entorhinal cortex, the amygdala, and the cingulate gyrus. Patients who have schizophrenia will have smaller volumes of the left hippocampus and the amygdala, and it's also found in high-risk non-symptomatic patients. When we're looking at the treatment of schizophrenia, we know that medications should be given. Now we know that antipsychotic medications, such as the typicals or the atypicals, will reduce symptoms. And in the studies, they have shown 75% versus 25% with placebo. Now we know that when patients take their medications, they will have higher rates of relapse. And even on medications, you will have relapse. So 40% of patients who have schizophrenia will have a relapse in 2 years if they stay on their medication versus 80% relapse in 2 years if they're off the medication. So understandably, your chance of relapse is greater if you're off the medication. Patients who have schizophrenia have a rule of threes, if you wish, when you're dealing with prognoses. About a third of them will lead normal lives, about a third of them will have symptoms but function, and about a third of them will have frequent hospitalizations.